In today's episode, I'm thrilled to speak with Dr. Scott Small, the director of the Alzheimer's Disease Research Center at Columbia University. Dr. Small is a globally recognized expert in Alzheimer's disease and cognitive aging. He's been researching the disease for decades, and his lab has pioneered MRI techniques that have identified areas of the brain most affected by aging and disease. It's a real privilege and honor to have the opportunity to speak with Dr. Small. In this episode, Dr. Small and I talk about his new book, Forgetting: The Benefits of Not Remembering. We explore why forgetting is not only normal and good, which is good news for me and everyone listening, but also a necessary and positive function for our brains. Dr. Small and I talk about Alzheimer's disease, the steps we can take to help prevent the onset of the disease, the latest therapies and drugs available, and what the future holds for Alzheimer's treatment. Scott, so nice to see you. Before we start talking about all of your amazing work that you've done in Alzheimer's disease research, I want to talk to you about your new book, Forgetting: The Benefits of Not Remembering. And I know I've experienced, and I think many listeners have experienced, moments where we can't remember what we're doing, where we parked the car, someone's name, and we worry that this is sort of the onset of a real memory disorder, or at least I worry about that. Will you just talk a little bit about what is normal forgetting, or what is positive forgetting?
Yeah, normal forgetting. I mean, it's a really good way to start because the book is about normal forgetting. My medical practice and my research is on pathological forgetting, and the two should not be confused. Pathological forgetting, as a rule of thumb, is whether a person notices a worsening from their own baseline gradually over time as we age. That's pathological, and we can get to what the causes of that are. Normal forgetting, in contrast, is what we're all born with, we all have. The interesting thing about the book is that we've always thought that both normal forgetting and pathological forgetting represented glitches in our brains, problems in the memory system. And the book is about it's inspired by the new science of normal forgetting, which actually makes the point that normal forgetting is a gift, not a burden.
You also just mentioned that, pathological forgetting it's distinguished from sort of what your normal baseline is. Should we be having cognitive tests from our general practitioner, or how and when do we look to have a baseline established, or would you not?
Yeah. No, that's a really good question. So you might know that football players now are required, or typically do get baseline, what we call neuropsych tests, neuropsychological evaluations. That's the formal term for the formal cognitive test. That is the most precise way we have to assess someone's cognitive abilities. We don't recommend it as we age, but there's talk of that. It's actually pretty interesting. People have done research on this. We're pretty good at assessing our own memory. So if someone really has worsening of their baseline, they will notice it. And I would suggest that's when you definitely should go see a healthcare provider. On this idea of maybe just like we get, annual cholesterol levels, maybe we get a neuropsych exam. There's been talk of that, but I'm not sure that that's worth it at this point. So in the book, you talk about sort of the benefits of forgetting for our cognitive and creative abilities. So that not only is it good for us, but that it's good for us in certain ways. Can you talk about that a little bit? Yeah, well, I mean, obviously, the book is all about that. Basically, the book is structured to first introduce the new science of normal forgetting, a little bit about how the brain remembers and forgets normally or not, and then chapter by chapter to illustrate the conclusion that normal forgetting is beneficial. I mean, we could say that, we just did, but it took a full book to make the case. And in each chapter, I do have a kind of an expert guide who leads me through different areas. Each chapter is influenced by different sciences, sometimes neurology, sometimes psychiatry, psychology, computer science. I could start telling you, although of course that's going to be a long-winded answer because it's essentially the book, but I can give you the overview and then you can choose which you find most interesting.
Yeah, well, I was thinking, for example, I know you spent a lot of time with Jasper Johns while you were working on the book, and I think that was in relationship to the creative component. Do you want to tell us a little bit about that?
Yeah, and actually, so just maybe first at the overview, because I think people intuitively understand what a few of the chapters are dedicated to, and that's emotional forgetting. I think people intuitively get that you need to emotionally let go to live a happier life, right? If not, you have PTSD. If not, you perseverate in pain. The less obvious benefits of forgetting are we think smarter and better. We can come back to that. But one of the chapters, as I've been lecturing on this, which I actually think is maybe the most important reason why nature has bestowed upon us this ability to forget, is to be creative. So if you want, I can talk a little bit about that.
Yes, please.
So obviously creativity is a big topic. Scientists always try to evaluate it. But it's good to start with the testimonials of people who are creative, and there have been books that have been written off of these testimonials. And to make a point, we all know people who are more or less creative. Obviously, artists, poets, musicians are professionally creative. But we all know that in any walk of life, you could be more or less creative. So when experts have poured through these testimonials to try to maybe capture the gist of what a creative mind is, it's not this complete eureka. We talk about the eureka moment as if it pops into the brain from nowhere. Most of the artists and creative types say that they do two things. They immerse their brains with a lot of relevant information. So let's think of a poet. They would immerse their brains with words, of course, and grammar and syntax, but they would make sure that the connections between the words are not stapled in steel. There has to be a certain looseness and playfulness, because what apparently defines the creative moment is this sort of cognitive alchemy, where suddenly two items have this unexpected connection. That is what I think a lot of people feel when they're being creative. That is what emerges from the sum total when you look into the minds of creative people. So to translate all that into neurological terms, the ability to immerse yourself in visual information, to create associations with words, with names, with numbers if you're a scientist or a finance person, that's memory. But to make sure that those associations are loose and playful, that's forgetting. And the important point, Leslie, to say, I should have maybe said this at the get-go, this book is not that forgetting by itself is beneficial. The insight is that you need forgetting together with memory. So you need this balance of memory and forgetting, just like a car needs a braking system and an accelerator. And so back to the creative, most creative people have learned to use that perfect balance. Yes, they have memory to store all sorts of information, but they insist unintentionally and subconsciously to use their natural forgetting to keep those associations loose and playful for those eureka moments. So in the book, I say that, because it comes out of the testimonials, that in some ways, too much memory moors us from creative flights of fancy. We're just too anchored, too stapled, too rigid.
So are you saying that because I do lose my keys and can't find my phone, that I am creative? Or are you saying that?
I'm saying that everyone loses their keys and forgets their phone. That is an annoyance, but I can give you examples of where you have too much memory. It's also an annoyance. The point is to realize that presumably nature bestowed us forgetting not to be annoying, but because it has some benefits to things like creativity, emotional well-being, and smart thinking.
Yes, you talked about the emotional well-being too in your book and personal health. Do you want to speak to that a little bit?
Yeah, like I said, that's sort of the, there's a lot to say, even though it might be more intuitive. But if people don't know, PTSD, post-traumatic stress disorder, is formally a disorder where that balance is out of whack with too much emotional memory. People can't emotionally forget the traumatic event, and they keep on playing it over and over. And it really speaks to the mechanisms of memory and forgetting. But it doesn't have to be pathological. I think I might have mentioned this to you before, Leslie. You and I are both long and happily married, but when I often lecture about the book, marital therapists, raise their hands and say, well, Dr. Small, we know you're developing drugs for Alzheimer's disease, but I promise you, if you develop a drug that will enhance forgetting, my marital practice will thrive. And I think
or be over. Or be over.
And here's the interesting thing. The interesting thing is that there are drugs out there that enhance fear forgetting, emotional forgetting. It's called, depending on what generation you're part of, either ecstasy, mollies, or MDMA. And before it was a banned substance in the 1970s, in fact, it was used by marital therapists to allow us to let go. In the book, I talk a lot about these terms we use in our everyday language. Just let go of something already. Letting go is just a colloquialism that nods in recognition to our forgetting abilities. The point is that the fear, emotional forgetting, which is part of this forgetting benefit, if it's dysfunctional, it can lead to true pathologies, PTSD. But as I say in the book, all of us we could be a little bit out of whack when we get, vindictive, self-righteous, rageful, angry spouse syndrome. That's not a pathology, but it is typically reflective of too much memory, too little forgetting. So that's just to give an example of where emotional forgetting is not just reflected in clinical patients, but in our everyday life.
So to really understand when forgetting would be classified more as pathological or of concern to you or to us, right? Because you were mentioning that we kind of all have our own baseline. What kind of things would we look for in ourselves or in a loved one where that kind of forgetting is not just sort of normal or positive forgetting, but is something that could be in the disordered range?
That's a good question. How do my colleagues, not I, diagnose PTSD? We've all have experienced traumas, post-trauma, but when is it a disorder? It really comes back to how doctors diagnose any disorder. And if it really, and like PTSD, we all have experienced events. You and I have experienced 9/11, and there are a lot of people with PTSD after 9/11, but not everyone has PTSD. So, why not? And probably because those who haven't, to a certain degree, have a healthy amount of emotional forgetting. But to answer your question, the clinician's requirement for something to be a pathology often is not just an X-ray or a blood test. Is it really affecting your day-to-day function? So, all kidding aside, if a married couple is really having a problem with, letting go, they should seek professional advice. If someone perseverates, think about OCD as a disorder in a way of too much forgetting, you should seek medical advice. Or just people have different feelings about psychotherapy, but if you just feel like your mind is flooded with information that you just can't let go, you can't sleep, that's an example where you can forget. And then psychotherapy might be beneficial. So there are ways of monitoring yourself and seeking help accordingly.
What about for those that are concerned that their forgetting might be either persistent or severe that it could be in a category, of early stage. And I know.
Okay, so now I think. Sorry to interrupt, but I think you're referring now to, well, what about pathological forgetting, right?
Yes. What about yes?
Hopefully, all your listeners now know to celebrate their normal forgetting and not to fight it. But what this book is not about, God forbid, and I'm very explicit about that in the first chapter, is not what sometimes doctors do, is they poeticize pathology. I got this horrible diagnosis, but there's a silver lining. I don't believe in silver linings. And certainly what I'm not saying is the patients that I see every week who suffer from pathological forgetting, there's anything good about that. We can talk philosophically about how do you live with pathological forgetting? But I'm just re-emphasizing the point that everything we talked about before was normal forgetting. Okay, so now if we get into pathological forgetting.
Because this is, besides your book, which is so interesting and is really, as you talked about all the different studies that you did to kind of get to this, to prove this thesis, right, that forgetting is actually beneficial. Your life's work is in Alzheimer's research.
Yes.
And so I guess for people who are listening that might either for themselves or for an older parent or for a loved one are concerned about their level of forgetting, is it normal? Is it age appropriate? Or is it something that is in a category that, where they should seek seeing someone like you? What are the warning signs for that, or what should a person be looking for?
So now we're into pathological forgetting, which typically occurs as we age. A doctor never likes to admit that there are just two diagnoses. There's a long list of diagnoses that we need to sort through. But basically, the most common things we consider when a patient comes to us and complains of noticing worsening forgetting is either the aging process or Alzheimer's disease. So let me parse those a little bit. By sometimes called cognitive aging. So I don't know about you, Leslie. I think so. I think I know you long enough to know that you're wearing glasses because of aging, or maybe not. I am.
Yes, I hit 40 like I was driving a car at 80 miles an hour, and my eyesight all of a sudden.
Exactly.
I was at 1 readers, 1.5. Now I'm at 2s.
Exactly, and that's what happened to me. I fell off a cliff. That is not a disease. That is normal. You don't have a retinal disease. You don't have an eyeball disease. You have presbyopia, which by definition means a change in your eyesight associated with normal aging. Much like the wrinkling of our skin, the whitening of our hair, it's part of the aging process. Now, just because it's not a disease doesn't mean that we shouldn't fix it if we can, and we do with our eyesight. There is something very equivalent in the brain, and areas of the brain that regulate memory suffer the wear and tear of the aging process. That's called cognitive aging. That's distinct from a disease, just like someone, when you went to your ophthalmologist, they ruled out glaucoma, retinal disease, and said it's just aging, wear glasses. In our field, the most common disease that could begin with very subtle memory loss is Alzheimer's disease. So the beginnings of Alzheimer's and cognitive aging could look very similar because they start in the same part of the brain. But over time, Alzheimer's becomes a lot worse and progresses, whereas cognitive aging doesn't. Now, we don't want to have to wait. We want to be able to make that distinction pretty quickly, and we're getting a lot better at distinguishing Alzheimer's from aging.
So, but what should somebody look for? Because I think you and I talked about this, and it was something like, it was not, I can't find where I parked my car, but I can't remember how to drive home, right? There was one or two things that you said were...
So look, I mean, let me just be careful because, you have a listenership. I can give you my rules of thumb, my gestalts. I mean, obviously, if someone really is worried about their memory, they should see a doctor because there are things that could be treated. It could be a rare form of a stroke or a vitamin deficiency, could be anything. But I obviously get asked often, and from around the world, people say, okay, sure, I get it. But give me, like what you were just saying, give me something that is a red flag when someone's when you're hearing a story. Now, you raised things that don't raise red flags. Forgetting keys, misplacing wallets, that happens to everyone. That could be early Alzheimer's or early if it gets worse, but it's not really distinguishing. To me, what is a red flag, and it's just a flag, is, as you were saying, if someone really forgets navigation, how to drive home, or when they get, what's the right subway to take home, that kind of spatial navigation forgetting is typically a red flag, because that's part of the brain where Alzheimer's begins. It's not definitive. Some people have always had bad spatial memory, some don't. But that is a red flag. When I hear about people getting lost, that worries me sometimes.
And this might be, the question that if you had the answer, you'd have all the answers. But contributing factors to developing Alzheimer's, what are they?
Well, actually, the list is quite short. The contributing, because it's a very complicated disease, almost by definition, it's called a complex disease. We can talk about a rare form of Alzheimer's that's simply genetic, but that's 1% of all Alzheimer's. If any of your listeners know anyone with Alzheimer's who's above the age of 60, it's almost certainly what we call the complex form of Alzheimer's, which is complex mix of the of genes in the environment. We can come back to that, but the things that are associated with increasing your risk are the things that are associated with almost every age-related disorder, and that's why it's almost like a generic recommendation from doctors to patients. So. Midlife obesity and type 2 diabetes is a strong risk factor. Cardiovascular disease is a risk factor. So all the recommendations of try to exercise, try not to gain too much weight, try not to smoke, try not to develop diabetes, hold for Alzheimer's disease. Beyond that, there's nothing, and there's a lot of people make claims, but often the claims are wrong. That's basically the only thing we can tell patients to do, or people in midlife.
That is really interesting. I mean, the smoking thing, everything fun, smoking and alcohol, I assumed were on the list of things we shouldn't be doing, but I didn't realize that weight would be, or cardiovascular health would be related to.
Yeah, these are risk factors. I have plenty of patients who are fit. It's not a simple cause. It's not a cause, but it's a risk factor, and we're trying to understand why. So and that's where a lot of the obesity drugs now, which is are all the rage, not just cosmetically, but obviously medically. I think that's a good thing because obesity leads to type 2 diabetes. Type 2 diabetes leads to cardiovascular disease. It's really the scourge of this era.
So those are things that are risk factors. Are there lifestyle choices that we can make besides staying fit to sort of lower our risk? I've read or heard, you want to, whether it's playing bridge or Sudoku, or is it called Sudoku, or is that a Star Wars? Whatever those puzzles are.
Yeah, cognitive exercises. I mean, I get that question a lot, and I completely know the brain is a plastic organ. I do know that if you don't use it, you lose it. What's interesting is that no one has been able to really prove exactly what kind of exercise to do, cognitive exercise. And so the recommendation is definitely engage your brain, but do it in things you enjoy, right? And there's no prescription. Don't spend a lot of money on something that's being sold. And actually stay socially engaged. That's another thing that's important. Older people often become lonely, and that's another risk factor.
So if one of our listeners has a family member, a parent in particular, direct family member that had Alzheimer's, should they be getting genetic testing to see if they're at higher risk? I have a friend who did that, and she's very conscientious about her lifestyle choices with the hope that she won't develop it. And I'm not even sure what gene they identified. Would you know what gene that might be, or what testing is out there?
I tested, but I'll first tell you if it's a recommendation or not. It really depends on whether there's any evidence that the person has a family history of the rare form of Alzheimer's I alluded to earlier, which is a genetic form. It's called early onset, autosomal dominant. If you have the gene, you get the disorder. That typically, there's a family history because your mother or father have to have had Alzheimer's disease, and it typically presents in one's 30s and 40s. And I have patients like that because we get patients from around the world. But if, the more common form, someone in their late 50s, 60s, 70s begin to have memory loss, and there might be some family history, but it's not very compelling, the recommendation is not to get any genetic testing. Now, I have a feeling she's in that category, and there are some genes that are risk genes, like ApoE4. I'm imagining she got tested for that, and there's a debate, but most of the recommendations in like New England Journal papers say it's just not everyone with this gene develops Alzheimer's disease. Many people without the gene do develop Alzheimer's, so it's this sort of risk. It's not really clarifying, and it often can cause too much concern.
I was going to ask, is that the reason why it's not recommended? Is because they don't want people to?
No. It's because you're not gonna really act on it. I mean, I guess if you had something to do for it, and it's not. By the way, not all genetic testing has to be actionable. That's a term. So, for example, don't know if you know about Huntington's disease, a very horrific disorder that is autosomal dominant. If you have one parent who has it and you get the gene, you will get it. There's no cure for that, but we still, when we suspect someone might have that, we actually have genetic counselors, because sometimes information alone is important. I would argue it is important. So it's not like you only get genetic testing if there's a drug. But the risk genes, not the causal genes, are just too complicated. They just don't help you think about anything. So I would only get a test for genes that are actually what we call causal. So if you think of a balance, the health balance, right? And there are many little pebbles that can cause you to have Alzheimer's disease, including maybe some things you've inherited from your parents. In the causal genes, it's like a boulder. You get the disease, but that's not the risk genes that we have in late onset. They're all little pebbles, and you don't know. Pebbles are just not very informative.
And is it because the research doesn't support that any of the lifestyle choices or steps that you could take to control those pebbles, it's not really proven that they do enough?
You can. Like the genetic part, you can't, not yet. But a healthy lifestyle, you can. Staying engaged. So all the things we talked about are environmental. You can. But that's actually exactly the point. Imagine that there are 10 pebbles, right? And you have a gene because you got it from your grandmother. That's a slight pebble, but the other pebbles don't exist because you're healthy and you're active.
I see.
Just knowing that you had that gene is not going to tell you whether you're going to develop Alzheimer's disease. The other kinds of genes I'm talking about, the boulders, you want to know.
And you only want to get tested for the boulders if you know you have those in your family. You wouldn't be looking for them.
Right, exactly. That's exactly. So, now, look, not everyone. Some people are adopted. Some people, so it's not always that simple. But as a matter of practice, that's true.
So once you have a patient who comes in and you have diagnosed them with having early onset Alzheimer's or onset Alzheimer's, are there effective treatments available?
So we're in a new era in Alzheimer's. We finally have a treatment that is going after some of the core features of the disease. And these are the anti-amyloid therapeutics. And it's important to emphasize, first of all, it's a kind of a revolution in my field, from where we had nothing to where we have something, but it's quick to add on to that it's just the beginning. These drugs do clear amyloid plaques, which is one part of Alzheimer's disease. So far, they have only a modest benefit, and there's all this debate in the field. You have to be infused twice a month or once a month. There are some real risk factors like bleeding in the brain. We can manage them. So it's exciting times, but better to have something than nothing. But I think most people are hoping that this is just the beginning of a new era of therapeutics in Alzheimer's disease. So I think there's a lot of excitement out there.
Is it one of the things where you want to be very conscientious about, even though there's really not kind of baseline testing out there, but if you have a concern about a loved one or about yourself, is the earlier the better? I mean, to go and see someone?
Yep, that is true. These drugs actually are only approved for people who have evidence of plaques and tangles and are relatively early in the stage. They're not approved for someone who is much more progressed. So, and I think that's just, there's a little bit of common sense there, like maybe cancer. You want to treat, cancer as early as possible. So, yes.
So if you suspect that you may have some disordered forgetting, right? It's a neurologist that you would go see. Is that your first step?
Typically, it's a neurologist. It could be a geriatrician. It could be a psychiatrist, but typically it's a neurologist. It could be any neurologist, but in tertiary centers like in our academic center, we have a division that's focused on Alzheimer's disease. So all of us are experts in Alzheimer's disease, but you don't need an expert to really just sort through the basic workup for Alzheimer's disease.
So you are really at the forefront of this research, and I know this is a big question, and I know I'm mindful of the time because your time is very precious, and I don't want to keep you much longer because I know how much longer I have you for. But can you tell us sort of what you're working on, and what do you think holds the most promise in terms of therapies that are being developed?
Yeah, sure. I mean, analogies are sometimes dangerous, but the pretty good analogy is I think most people know about statins, Lipitors. Many people are on it. It's a cholesterol lowering drug. And it has a significant impact on reducing cardiovascular disease because cholesterol lipids accumulate in your blood vessels where they cause lipid plaques, and they can cause heart attacks, strokes, etc. And people had known this for a while, and you can think, well, I can try to clear those lipid plaques from the blood vessels, and that sometimes has to be done surgically or with stents. But I think everyone intuitively knows the better way is to try to understand why the cholesterol was accumulating in the first place, from what cells in the body, and to try to correct that problem before there's blood vessel disease. And that's basically the story of how the statins were found. Statins, are you familiar with statins?
Yes.
Yeah.
Yes.
So they basically work by...
But actually, maybe for listeners, it'd be great to...
Yeah, no, I mean, most people, what they do is they basically target the cholesterol metabolism pathway in your liver cells. So most of the cholesterol is produced in your liver cells, and these drugs, which are transformative, they correct the abnormal secretion of cholesterol of your liver cells into your blood. That's what statins are. That's what's one of the great success stories of 20th century medicine. So right now in Alzheimer's disease, I'll decode that analogy. Amyloid plaques are found outside of neurons. They're found in between neurons. And the drugs that currently exist clear the amyloid plaques from between neurons. But most of us feel like if we ever want to develop statins for the brain, we need to start looking into inside the neuron, what's gone wrong to cause the neuron to secrete these amyloid proteins. And the good news is that we now know a lot of that biology. So the reason I've shifted from pessimism just a few years ago to cautious optimism is because we now know the biological pathways, and now we just need to develop drugs against those pathways. I have to emphasize, Leslie, in the effort of being transparent, that I've helped co-found a company based on one of these pathways because it's a pathway that I've been involved with. So.
A company is developing a drug to try to
basically develop a statin equivalent for the brain. Yeah,
that's amazing. And my next question: what do you need, or other researchers like you? I know there are not many researchers out there like you with your.
No, there are a lot. There are
what do they need? Is it a lack of funding? Are researchers sharing information? What are the barriers?
Yeah, that's a good question. It's something that the new dean at Columbia, Katrina Armstrong, has asked me to tackle. In general, what are the barriers to the advancement of medicines? It's a big question. The first thing to say is that the ecosystem for developing medicine usually starts with us academics, finding a pathway, understanding if it's causal. But the best road to drug discovery is really then at some point collaborating with industry. And that's the right dance in my mind. All academics would want more funding, and of course we can use more funding. I think the real barrier for Alzheimer's disease has been finding the causal biological pathways. Until recently, we've been shooting in the dark. So just to maybe go on about that a little bit, every neuron of ours has, a few hundred pathways. Just think of one of those complicated blueprint diagrams of your computer, right? There are all these things that are interconnected. There's one pathway among those that is at the root source of a disease. That's the assumption in biomedical research. Finding that in Alzheimer's has been extremely difficult because it's not like a skin cancer that we can quickly scrape it and look under the microscope. Historically, we had to wait decades until a patient died and then looked at the brain under the microscope. So there's a lot of reasons why it's taken a while to find these really fundamental core pathways that trigger Alzheimer's disease. But finally, we have a few that everyone acknowledges are that really are the triggers of Alzheimer's. Once you have a biological pathway, the biomedical enterprise is so sophisticated that you would imagine that you will find a drug. And the one thing I like to emphasize is look what happened with COVID, right? It took Jonas Salk 20 years to find a vaccination for polio, at least. And yet here in 2 years, we had a equivalent vaccination for a brand new virus, which we've never seen before. And that just shows you the capabilities of the biomedical enterprise once you know what to try to fix. So that's the reasons why I'm sort of optimistic that we're on the right track.
That's very exciting. I think that's really exciting. It is one of my mother-in-law, as you know, had Alzheimer's. She passed away from COVID, actually, but she had Alzheimer's, and there really was not very much that could be done for her at the time that she was diagnosed. I know she was on a drug, and I can't recall what it was called, to
Probably
slow.
Aricept.
Yes.
Yeah.
Yes, exactly. Aricept, I know. I can't remember if there were others as well, but just to sort of slow the process of down. But so it's really exciting for people, and I think that it's interesting. I've had a couple interviews with people on subjects related to mental health and cancer, and there were comments from both of those guests about how collaboration is something that is missing, right? You have Sloan Kettering doing something, you have MD Anderson doing something.
Yeah, I hear that a lot, but I actually don't find that. I mean, I'm off to a meeting Saturday where there's a lot of collaborations. Yeah, I mean, there are some egos, but we're pretty collaborative. So,
so you feel like in your space that research is being shared. Well, I guess now you were saying now you actually know. You all know what you're shooting towards.
But that knowledge came. We have weekly meetings with an international group of investigators that all work on this pathway, and there's someone from Holland, from Denmark, from the West Coast, East Coast. So maybe that used to be true, or maybe I'm just by nature more collaborative. But that's not the barrier. I think the real barrier has been finding what's fundamentally wrong. And I think we're getting closer to that.
Oh, it's so exciting. It's so exciting. Scott, I mean, this is really such an incredible honor to have you today, and to have the amount of time that you've given me today is really terrific. I don't know if all our listeners understand just what a superstar we have here with us today. So I'm really, really thrilled and really grateful to you for taking the time. And it's good to know that my forgetting is right now, at least for right now, in the normal phase. And it's good. I think it's been very helpful for listeners to know what steps they need to take if they are concerned, and what things they can do to try to, lead a healthy lifestyle to prevent developing any kind of pathological forgetting in the future. So
great. Well, thank you.
Thanks, Scott. That brings us to the end of this episode of the interview. A huge thank you again to Dr. Scott Small for joining us. And as always, thank you again for listening. If you enjoy the show, please rate and review us on Apple Podcasts and follow us on Instagram at The Interview with Leslie Heaney. A new podcast is released every Wednesday. Until then, this is Leslie, and don't forget to join The Interview.